So again, one of the themes of this session this afternoon is to take cues or take lessons from other disorders that we feel are due to interactions between the nervous system and the immune system, and try and decide whether they can teach us lessons about the pathogenesis of transverse myelitis. So I'm pleased to introduce our next speaker, Dr. Jack Griffin, who's the chair of the Department of Neurology here at Hopkins, who's going to tell us about lessons from another neurological disorder known as the Guillain-Barre Syndrome, and what that might teach us about the pathogenesis of transverse myelitis. Dr. Griffin.
Well, first of all, thanks, Dave, and I very much appreciate the opportunity to talk with this group. I'd be curious for individuals in the audience who have transverse myelitis, how many had a diagnosis of Guillain-Barre syndrome made when they first presented, or at least have that raised as a question? So a fairly high proportion. In fact, the Guillain-Barre syndrome and transverse myelitis have a number of similarities and parallels. One of those is that there is a semi-annual meeting of the Guillain-Barre Foundation International, which is organized out of Philadelphia, and I've participated in I think all of those meetings now. They are very wonderful meetings from the standpoint of physicians, I think, as well as patients. And this clearly is a meeting that has the same kind of spirit that the GBS meetings do. Guillain-Barre syndrome has a number of similarities as well as differences from transverse myelitis. Both obviously are rapidly evolving paralytic diseases. Guillain-Barre syndrome is a disease of the peripheral nervous system rather than the spinal cord. Like some cases of transverse myelitis, it can follow infections. The prognosis in GBS can clearly be improved by early treatment. I'm going to tell you a bit about the history, and again, there are some parallels. In 1859, Landry in France described a number of patients who had acute paralysis, and it was said to be flaccid paralysis because the tone, the resistance to movement of the arms and legs was reduced. And he thought that was due to neuropathy. Now, the reason he thought it was due to neuropathy was that he had pathology on autopsies of some of those individuals, and he found no spinal cord involvement. So what we can really say about Landry's cases was that they were not transverse myelitis. The real definition of the syndrome came in 1916 in a series of French soldiers who came out of a trench warfare setting in World War I. And were described by Guillain, Maurice Barré, and André Stroll. And they identified what they called a triad of weakness of muscles, loss of tendon reflexes, and high spinal fluid protein without cells. And that was an important aspect at the time because the real paralytic disease that was around in 1916 was, of course, polio. And you would expect the spinal fluid to have inflammatory cells in viral poliomyelitis. So that their disease was exciting and was a discovery because it was a paralytic disease without polio, or without cells in the spinal fluid. In fact, for years it was referred to as French polio. In 1969, Art Asbury, Barry Arneson, and Ray Adams in Boston looked in the first time really systematically at the pathology of Guillain-Barre. And what they found was that demyelination, loss of the myelin sheath, and variable degrees of loss of the whole nerve fiber, or the axon, was present. And in addition, there was lymphocytic infiltration. And they equated Guillain-Barre syndrome with acute inflammatory demyelinating polyneuropathy, or AIDP. Now, this was in 1969, and at about the same time, there were other disorders being described that had a lot of relevance to this, and we'll talk about those in just a minute. they identified, and a number of other people pointed out similarities between transverse myelitis and Guillain-Barre. Both can have abrupt onset in previously healthy individuals or individuals with relatively trivial antecedent infectious diseases. So the antecedents can include diarrheal diseases, viral syndromes, and so on. In general, the most severe state is reached in a period of certainly 1 to 4 weeks in transverse myelitis, actually probably faster most of the time, and by definition in 1 to 4 weeks in the Guillain-Barre syndrome. And there are many reasons to think that there is immune mediation. In fact, both Guillain-Barre and transverse myelitis can develop in individual patients. We've seen a number of examples of that. And Dave Ronnie referred to the experience after the simple rabies vaccine in Southeast Asia, where again a number of individuals have both Guillain-Barre and transverse myelitis in that setting. There are important differences. Transverse myelitis, of course, affects the spinal cord primarily. Guillain-Barre affects the peripheral nerves and the nerve roots primarily. The effect of acute interventions in transverse myelitis, I think it's fair to say, is largely uncertain, whereas it's now absolutely clear that in the Guillain-Barre syndrome, 2 therapies, plasmapheresis and use of intravenous immunoglobulin, are effective. Corticosteroids are by themselves ineffective. And finally, late improvement in transverse myelitis several months after the onset is relatively infrequent, or at least qualitatively not of the same degree that occurs with the Guillain-Barre syndrome, where late improvement by nerve fiber regeneration and reinnervation of muscle is the expected outcome. Now, when we talk about involvement of the peripheral nervous system, this is the spinal cord looked at in cross-section. We're really talking about involvement of the nerve fibers that run from the spinal cord out to the muscle through, for example, in the leg, nerves like the sciatic nerve and the femoral nerve, and the sensory fibers that come back from sensory endings through the sensory nerves and into the spinal cord. You'll be paralyzed if the spinal cord itself is damaged because the control of these motor nerve cells is lost, but equally paralyzed by damage to the outflow from the spinal cord to muscle. And often it is very difficult to know at a time a patient presents with new paralysis whether the involvement is at a spinal level or a peripheral nerve level. And that's the reason that Guillain-Barre is invoked so often in transverse myelitis and vice versa. Now, this is simply a demonstration of the effect of treatment. This doesn't have a control group on here because by the time the study illustrated here was done, it was not appropriate to have control groups. But this is a graph that illustrates the improvement in disability over time after onset. And in untreated individuals, the improvement is much slower, so a curve would look much more like this. As an indication, in patients with Guillain-Barre sick enough to be on a respirator, their time to resume walking is, on the average, about 6 months, or it was. With the advent of plasmapheresis, that number was down to about 2.5 months. So it makes a big difference in the speed of recovery. Now, those kinds of studies in the Guillain-Barre syndrome take enormous numbers of patients, and my suspicion is that will be true as well in transverse myelitis. At the time I got interested in Guillain-Barre, it was apparent that steroids alone had no obvious benefit. And we had done for the first time plasma exchange or plasmapheresis on a patient with a chronic inflammatory demyelinating neuropathy in Baltimore, and it had a just extraordinary improvement in his symptoms. So it seemed attractive to do plasmapheresis in the acute inflammatory demyelinating disease, the Guillain-Barre syndrome. This was in the early 1980s. So we asked our friendly neighborhood statistician, given the variability of Guillain-Barre, how many patients would we need to tell that we were making about a 30% improvement in a patient's prognosis? And he calculated for a bit and said, oh, only 260. Well, we see about 20 patients a year, and so we did a little multiplication, and it turned out that in our lifetime we probably could complete the study, but in fact that required a multi-center study involving at that time 23 patients, and the outcome was dramatically in favor of plasmapheresis, something that was not known until the night the code was broken. Because by simple anecdotal information, I think most people couldn't see a big difference. And I would point out that there has been no comparable experience with transverse myelitis, so that while we may say, well, we don't think a given therapy makes a big difference or that one therapy has some effect, it's very hard to know without comparison of large groups, particularly because transverse myelitis, like Guillain-Barre, is a somewhat heterogeneous disease. Now, this was confirmed by French and Scandinavian trials, and a Dutch group led by Frans van der Mache and subsequently Richard Hughes in England showed that intravenous immunoglobulin is exactly the same as plasmapheresis, and how similar they are is shown here, where you really superimpose the rate of improvement from plasmapheresis alone, infusion of intravenous immunoglobulin, and the combination of the two. There is no additional benefit to combined therapy. Now, let me go back to 1969, at the time that Guillain-Barré's pathology was first being identified. At about the same time, experimental allergic encephalomyelitis was being looked at in a systematic fashion by Brian Waxman and others in Boston. This is the disease that Dave Ronning mentioned before, that's produced by immunization of appropriate animals with central nervous system myelin or myelin basic protein. And it was put forward as a T-cell mediated inflammatory demyelinating model of CNS disease. In fact, these animals get a degree of spinal involvement, but it's been looked at primarily because of its potential relevance to multiple sclerosis. At exactly the same time, the same workers were immunizing animals with peripheral nervous system myelin or specific myelin proteins and producing a disease they called experimental allergic neuritis, or EAN. And this was a T-cell mediated inflammatory demyelinating disorder of the peripheral nervous system. The analogy with these experimental allergic models suggested that perhaps MS, transverse myelitis, and Guillain-Barre syndrome might all reflect a cell-mediated immune attack on intrinsic myelin proteins of the tissue of interest, the CNS in the case of MS and transverse myelitis, the peripheral nervous system in Guillain-Barre. And that still remains a very attractive possibility, but I think one of the messages that will come out is that almost certainly the central nervous system diseases and the peripheral nervous system diseases are more heterogeneous than this graph would indicate. Certainly, as we look at the Guillain-Barre syndrome, the newer perspectives are that the Guillain-Barre syndromes, as I like to call them, are heterogeneous. The pathogeneses of two minor variants of the disease, something called the Fisher syndrome, which we won't say a great deal about, and the AMAN syndrome, are increasingly well understood in terms of what the antecedent infections do to produce the disease, the target of the immune response, and the immune effector mechanisms. And I think that it's worth keeping in mind the possibility that the Guillain-Barre story has parallels in the central nervous system in terms of multiple sclerosis or transverse myelitis, that there may be a degree of convergent evolution of research progress in these areas. That's only a hypothesis at the moment, but it's one I think that's worth keeping in mind. Now, we call these minor variants because in this part of the country or the world, the acute inflammatory demyelinating disease is by far the most common form of Guillain-Barre, and these are somewhat different. But I will tell you that worldwide, probably these are the most prevalent syndromes, and I'll show you why. This is a useful chart of the various forms of the Guillain-Barre syndromes. This is acute inflammatory demyelinating neuropathy, the diagnosis made at least 97% of the time in this part of the world. These are the so-called axonal forms in which, for reasons you'll see, there's evidence of a primary immune attack on the axon rather than the myelin sheath. And we divide them into two flavors, acute motor axonal neuropathy, or the AMAN syndrome, and acute motor sensory axonal neuropathy, or the AMSAN syndrome. How these two relate isn't clear, but I think it's entirely possible this simply is a more severe form of this disorder. The Fisher syndrome is very different. It's a disease that has limitation of eye movements, of pupillary responses, and a gait unsteadiness without weakness. And it has a very clear and distinct mechanism of development compared to this disorder. And there are clearly other forms that we're beginning to recognize and beginning to understand the targets of the immune attack. Now, let me talk a minute about the typical acute inflammatory demyelinating polyneuropathy, or AIDP. I think it's fair to say that virtually all cases that come to autopsy do have lymphocytic inflammation, but the severity varies very widely, so that in some cases you have to really look hard to find any lymphocytes, even in a setting of massive ongoing demyelination. In many cases, no matter how hard you look, there's no evidence of antibody deposition, immunoglobulin deposition, or of one of the effector mechanisms by which antibody can damage tissue, and that's by use of another protein called complement, which can get activated and produce damage. So that these cases resemble experimental allergic neuritis in the absence of antibody, the absence of complement, in the, at least as looked at pathologically in the tissues. Other cases have very prominent immunoglobulin antibody deposition on the nerve fibers, have evidence of complement activation, and in these cases a peculiar form of demyelination called vesicular demyelination, and I'll show you that in a moment. In AIDP, the target of the immune attack is unknown. I think that's fair in virtually all cases. This is one of those cases of AIDP in which there is evidence of complement activation on individual nerve fibers. These same nerve fibers tend to have IgG antibody on their surface, but it's interesting for pathologically oriented people that the brown reaction product that indicates that complement has been activated in the site is on the very outside of the nerve fibers, not in the myelin sheath per se. And in these cases, if one takes an individual nerve fiber at the plastic section level, at the light level, and then looks at it at the EM level, you see an outstanding correlation of vesicular demyelination with this pattern of antibody and complement deposition on the surface. So that we think in some cases the effector mechanism immunologically is antibody. And that's important because that carries the implication that removing antibody might improve the prognosis, that plasmapheresis, for example, might be beneficial. In other cases, I must say, we see much less of this. Now, I'm going to leave AIDP for a moment and simply remind you that in this disease, the attack is on the myelin sheath itself. This is a spinal cord with the motor nerve fibers and sensory nerve fibers coming out, the individual nerve fibers, and here is an inflammatory cell, a macrophage, illustrated attacking the myelin sheath. In the Fisher syndrome, with its very different clinical picture, there are reasons to identify antibody-mediated attack on motor nerve endings, especially in the muscles of the eyes. And I will just tell you, without elaborating it, that in the Fisher syndrome, the antibody that's associated with this reaction is against a particular kind of compound called a ganglioside, and one particular ganglioside, GQ1b, is the target. I think the importance of that will become clear as we talk about the axonal syndromes, and that's what this diagram illustrates, in which an inflammatory cell, a macrophage, is coming to the electrogenic site, the node of Ranvier of an individual nerve fiber. So these are the axonal forms again, acute motor axonal neuropathy and AMSAN. This is a disorder that we really came across by dint of what we call the China Project. And the history of this, I'll tell you in a moment. If one looks at the proportion of these various forms of GPS around the world, in Europe and the U.S., AIDP accounts for about 97% of cases. In the developing world, and I guess we have to include Italy in that category, the Fisher syndrome is about 6% and axonal syndrome about 10%. We're awfully close to Little Italy, so I have to be careful. In Argentina, and this is in children, but I think the same applies probably throughout South America to children and adults, the AMAN syndrome, one of the axonal forms, accounts for about 20%. In Japan, the AMAN syndrome is prominent, although we don't really know exactly the percentage. And in northern China, it accounts for 65 to 80% of Guillain-Barre cases. And northern China is where we've done our work. Now, the reason that I'm going to spend some time talking about the AMAN syndrome is that it really represents, at the moment, the best studied and documented case of this issue of molecular mimicry. And this is one attractive mechanism by which an acute immunologic process can cause damage to nervous system tissue and allow it to be understood in terms of mechanism. The term implies that in this case an infectious organism has as part of its structure these blobs, which could be proteins, sugars, or whatever. I should tell you, by the way, that I'm colorblind, and my wife has pointed out what extraordinarily homely colors have been chosen for the antigen. So maybe it's just as well that one's trying to get rid of them with the immune response. At any rate, the immune response is generated against these components of the organism, and by bad luck, the nervous system normally has that same component, or a very similar one, on nerve fibers, so that the immune response sees shared antigens or epitopes that are shared between the infectious agent and normal nerve fibers. And so the immune response believes it's doing a good thing by attempting to attack and destroy those antigens. But if they're on nerve fibers, the consequence is damage to some component of the nerve fiber. That's the concept of molecular mimicry, and it almost certainly operates in at least the AMAN syndrome and the Fisher syndrome. So we've been studying the AMAN syndrome for about 10 years, and out of that really comes 4 points. First of all, the Guillain-Barre syndromes are heterogeneous. These axonal forms exist, a controversial point initially. They are associated with a previous infection with one particular organism, and that is the bacteria Campylobacter jejuni. Campylobacter is a gut infection. It's the most frequent cause of diarrheal disease worldwide, bacterial cause of diarrheal disease. It also can infect people without producing any symptomatic diarrhea. And it seems clear now that the axonal forms represent an immune attack on axonal gangliosides, and that antibodies made against the relevant gangliosides can reproduce the pathologic process of the axonal disorders. Now, the group that was involved in these studies consisted of Art Asbury from the University of Pennsylvania, Guy McCann, Dave Kornblath, Tony Ho, and especially in the last 3 years, Kazim Sheikh, who's done really the most important studies at Hopkins. And this man, Chunyan Li, from Second Teaching Hospital in Shijiazhuang, Hebei Province, China. And basically, 10 years ago, he introduced us to a disease in China that was different than Guillain-Barre as we knew it. It consisted of a disease in which there were summer epidemics. His hospital would fill with 200 to 250 individuals with this syndrome over the summer. They were predominantly children. They came from the countryside where they cared for animals, chickens, and so on, and there were no family or village clusters. One individual in a given village would get sick at a time. So it was an unusual epidemiology, very different than Guillain-Barre as we see it in this country. This has been a very instructive child who we affectionately know as HB 9313. He was a farm boy who developed acute flaccid paralysis. Interestingly, he had a series of paralyzed chickens with diarrheal disease at home. Campylobacter organism was isolated from his stool, and I should add from the chickens that were brought in. He recovered over about 6 months, but the organism that was recovered from his stool was subsequently used to infect other chickens and produce a very similar kind of disease. What we now believe is the case is that enteric infection with specific kinds of Campylobacter, and the exact designation isn't important, lead to the production of an immune response against ganglioside-like antigens that are in the cell wall of the bacteria. And those antibodies that are generated are IgG antibodies against GD1A ganglioside. You can get similar syndromes if the antibody is against a derivicized GalNacGDla or against GM1b. The binding of these antibodies to the ganglioside on the outside of the axon, combined with the activation of complement, the recruitment of monocytes destroys the axon at that site. And downstream from that, because any interrupted axon degenerates, there is degeneration of the axon. Now, pathologically, in a series of very well-preserved autopsy cases, what we see routinely is that there's binding of IgG antibody and activation of complement at the nodes of Ranvier, that is the site of impulse conduction in nerve fibers, involving motor fibers only, with some binding in the internodal axon surface as well. The macrophages come to the nodes of Ranvier. They enter the periaxonal space and are associated with breakdown of the axons in the absence of lymphocytic inflammation. This is simply immunocytochemical evidence, which doesn't seem to project very well here, of very focal binding of IgG and of complement activation at the nodes of Ranvier of individual teased motor nerve fibers. At these sites of antibody binding and complement activation, you also routinely see macrophages that have come in and are extending processes or fingers right into the node of Ranvier. And again, while this doesn't project very well, I'll tell you that that's the case for each of these nodes that are shown here. So that what we think is happening is that antibody and complement bind to the surface of the axon at the nodes, that products of complement activation call macrophages to that site, and that subsequently these macrophages can also dissect beneath the myelin sheath. And they do so because IgG binds to at least some axons on their surface inside the myelin, right in the periaxonal space, and complement is activated in the same sites. Macrophages are called into those sites, and this is an example of a nerve fiber looked at the electron microscopic level, where individual axons, and by the way, I should tell you that pathology of peripheral nerve is very easy because axons always have an A on them, and macrophages always have an M, so that it's one of the things that has made peripheral nerve pathology a very attractive field. So the axon here is surrounded by a macrophage, as you see here. The macrophage has no interest whatsoever in the myelin sheath. It leaves it alone, but it does extend processes that reach around and simply dissect the axon from the myelin sheath. This is a macrophage process. This is the axolcmma, the inside of the Schwann cell cytoplasm. And again, the myelin is left absolutely pristine. In time, the axon is entirely surrounded, broken down by the macrophage. And the upshot is that one ends up with a transection of the nerve fiber at that site. Now, this isn't demyelination, so recovery can't occur in these cases by remyelination, but only by axonal regeneration. The antibodies that are present are those directed against GD1A predominantly in China, and I'll show you that on the next slide. When we look at the antibody titers, there are extremely high titers of anti-GD1A antibodies. Those are virtually absent in now over 60 AIDP cases. This one actually is one that had some axonal involvement. They are very uncommon in U.S. Guillain-Barre and in all sorts of other controls, including Campylobacter diarrhea without the AMAN syndrome. They're uncommon as well. Now, to really show that GD1A was the target, and that one could reproduce this disease, we wanted to make anti-GD1A ganglioside antibodies. But it turns out when you try to immunize experimental animals with a ganglioside, the immune system says, I've seen this before. It's all through the nervous system. It's in a lot of other tissues. I'm not interested, and I'm not going to make antibodies. And in fact, it's been very disappointing to try to raise antibodies. Kazim Sheikh took advantage of the fact that he was involved in engineering a mouse in which the enzymes required to make complex gangliosides had been genetically knocked out. They didn't exist. These animals then couldn't make complex gangliosides, and when they saw a ganglioside injected as an antigen, it was the most exciting thing their immune system ever saw. They generated enormous antibody titers, and they have been used as a tool to make anti-ganglioside antibodies and to transfer the disease then to normal mice. And although I won't talk about it, to cultured spinal cord and motor neuron preparations. When Kazim made those antibodies and made cell lines that were generating pure IgG antibodies against the ganglioside of interest, GD1A, and then implanted those cells into a normal mouse and looked in plastic sections at the spinal cord, the nerve roots, and the muscles, what he found, first of all, was a large amount of degeneration of nerve fibers out in the intramuscular nerves, with an occasional demyelinated fiber, but most of them undergoing nerve fiber degeneration. In addition, at the level of the ventral roots, he found extensive Wallerian-like degeneration, typical of what we see in the human autopsy cases, and was able to show as well that normally the antigen, the appropriate ganglioside, was present at nodes of Ranvier of those motor fibers and in motor fibers preferentially. So that we end up thinking that this disease is a disease in which the antigen of interest is localized particularly at the nodes of Ranvier of motor fibers, that an antibody is produced that sees that antigen and macrophages come in to attack it. That the antibody is seeing a particular lipid ganglioside marker, and that one of the reasons that plasmapheresis is successful in Guillain-Barre syndromes may be that antibody is being removed, antibody that could otherwise initiate this process. Now, is this at all relevant to transverse myelitis or to multiple sclerosis? Well, I think that there's been a variety of new data in the multiple sclerosis area arguing that there's more heterogeneity of pathology and pathophysiology than previously recognized. And Claudia Lucinetti, who will be here tomorrow, and Hans Lossmann in Vienna have been involved in some of those studies. In some situations, it looks as though there's prominent axonal injury as well. Antibody-mediated demyelination can have vesicular changes, and again, a group at the University of California and in New York have looked at that. There are some patients with multiple sclerosis with particular clinical features that appear unusually responsive to plasmapheresis. Moses Rodriguez at the Mayo Clinic has identified such cases. And finally, there are clinical implications of axonal loss as well as demyelination in multiple sclerosis. It may well be that each of these points could be applied as well to transverse myelitis, but I think we don't know at this point how well that might occur. And finally, I should just show you the people that are actually useful in these studies, and in particular Kazim Sheikh, who's responsible for most of the pathogenetic studies, and Michael Lunn, who was in London when this picture was taken, but with the advantage of Photoshop, you would never know it. Thank you.
We're distinctly on schedule. Thank you, Dr. Griffin. You might even have a few minutes for a couple of questions if anybody would like to ask.
Yes. Well, I think the question was about whether infusion of human immunoglobulin was helpful in Guillain-Barre. And the statistical means by which you know that it's helpful are a little bit complicated, but it means showing in a large population of patients that those who get treated do substantially better than those who don't get treated. So the story about the time to walk was that without treatment, if you're on a respirator because of paralysis, the average time to resume walking is about 6 months. It is less than half that time if you're treated with either intravenous immunoglobulin or plasmapheresis. I don't think we have comparable data about transverse myelitis, except in very small collections of patients. Yes. Well, that's a very interesting story, and I think there is a lesson. I am personally convinced that that there are settings in which both Guillain-Barre and transverse myelitis occur at the same time in the same patient. And I've seen one very memorable individual who clearly had predominant involvement of the spinal cord in one episode and predominant involvement of the peripheral nervous system in another episode, although both of them were mixed. One of the reasons that it's been a sort of a tricky issue is that the diagnostic criteria for GBS, and I suspect for transverse myelitis as well, exclude involvement of the other system. But those are really for research studies, and in the real world, there is involvement of spinal cord in a significant number of Guillain-Barre cases. One of the pathologists in Vienna has looked at autopsied cases of Guillain-Barre and identified spinal cord pathology in a significant number, so that what you're describing is a very unusual event, and it's one that we ought to keep in mind because it's quite instructive. But in fact, some overlap involvement of the other system may be much more frequent than we usually think.